Okay, I think we're live. So this is the final day of British Science Week, and we have been doing a series this week focusing on the different aspects of STEAM, so science, technology, engineering, arts, maths, and medicine. So I am Dr. Alice Mills, one of the founders and directors of Exeter Science Centre, working to create a STEAM Discovery Centre in Exeter. And today in our series, it is M for Medicine Day. And naturally, British Science Week this week has fallen in the middle of a global pandemic, so we can't really talk about anything but COVID-19. And we're very, very lucky to be joined by the wonderful Dr. David Strain, who is a senior clinical lecturer at the University of Exeter, as well as being the clinical lead for COVID in the Royal Devon and Exeter Hospital. So David, thank you so much. I'm really sorry we had some technical difficulties, so we're starting a bit late. But thank you for joining us, and thank you so much for being here today and taking some questions. Please do write some questions in the comments if you've got any questions for David, and this is just a chance to learn more about the amazing Southwest response to COVID-19 and the contribution that Southwest clinicians and researchers have made. So yeah, David, thank you. If you could just start by talking a bit about what you do.
Yeah, thanks, Alice. So I've got lots of different roles, and actually they've all expanded during COVID. So primarily I am a clinician working with older adults, and in a pre-COVID world, I was doing research into diabetes, particularly focusing on the microcirculation. And we will come back to the importance of that in a moment. But also, I've been doing a fair amount of work about epidemiology. My background is looking at the difference in the different ethnic groups with the susceptibility to disease. So I think one of the first things that Exeter actually played a lead role in the COVID pandemic was looking at the risk assessments of people to go about their daily work. It became very clear early on in the pandemic that some groups had a higher risk of ending up in hospital or ending up dying of COVID. And with my British Medical Association hat on, we were looking particularly at the healthcare workers who are on the front line and therefore didn't have any choice in their exposure about how we could mitigate the risk. And one of the things that became apparent is that some ethnic groups, particularly those of Indian Asian origin or Black African origin, had a much higher risk of developing severe COVID that put them on ITU and eventually dying. There were a few other risk factors as well. So there was the advancing age, which was a rather expected one. But then there was also diabetes, cardiovascular disease, peripheral vascular disease. And they are not the sort of risk factors that you would normally associate with a respiratory disease. So right back in April, May time, we started seeing these figures coming in from around the world. And the Europeans, the Italian was the best data that we had to base it on. And we put together a risk assessment tool. Now, it was a very, very crude. The first iteration of this was very crude. We basically just gave you a point if you were a male compared to being a female, because males had a higher risk. 2 points if you had African origin or African ancestry, a point if you had Indian Asian origin or from Filipino origin. If you had certain diseases, so heart attacks or strokes, they would put you at high risk. And we just totted them all up. And if you scored more than a certain amount, you were thought to be at higher risk. This was rapidly rolled out across the whole country. This became the British Medical Association's go-to risk assessment tool. And this is before we had the acute COVID or the COVID age or the far more sophisticated tools that we are now using. But actually, in Exeter, we led the way. We produced the first risk assessment tool that reduced the risk of exposure, the risk of people dying and ending up in ITU, not just in the healthcare setting, but it was widely used in churches, in public transport, in places where exposure was inevitable. And as a result, we managed to reduce the risk of those with the highest chance of ending up in ITU and dying coming into contact with the virus. And I think that's probably the first thing that we did that made such a big impact in COVID coming down the line.
Amazing. It's yeah, such an important thing. And you did actually get COVID-19 quite early on in the. Was it early on in the pandemic that you
No,
got
no,
it?
it's right at the start of the second wave that I caught it. So
Okay.
I got through the whole of the first wave from April right through to, when we started closing COVID services down in July, without any problems whatsoever. And then in the second wave that came along, actually just as the new variant started to raise its ugly head, that's the point that myself and actually several other healthcare workers who'd got through the first phase caught COVID.
Yeah.
And again, this is something else that we have been right at the forefront of Exeter. So you will be aware that there are all these different variants of the virus going around at the moment. And people talk a lot about the Kent variant or the South African variant or the Brazilian variant. And actually, even if you look at the UK, we've got the Kent variant, but then there's another version that arose in Bristol, another version in Liverpool. And you could be mistaken for thinking that the UK is becoming this melting pot where all of these different variants arise. And the reality is not that. The reality is that the genetic testing program in the UK is the best in the world.
Mm.
And actually, of the world, of the UK, here in Exeter, we have some of the best gene sequencing anywhere in the country. To put things into perspective, in the UK, we do 8 times more tests than the next nearest country. We've done more genetic testings in the UK than the whole of Europe. And interestingly, the next nearest country to us is South Africa. And of course, we're all aware of the South African variant. So the fact that we're identifying all these strains in the UK is not because we are producing more than anywhere else. It's because we've got the technology. We've been right at the forefront at looking this. And actually, the data that you may have seen on the Prime Minister's Downing Street briefings from the Chief Medical Officer and from the Chief Scientific Officer, Sir Patrick Vallance and Chris Whitty, they have all come from data that's derived here in Exeter. Wow. Exeter was the first place to identify that this new variant had a much higher transmission rate. The new variant is 70% more transmissible. They were the first place to identify that despite hospitalizations weren't up, that the mortality from this new variant was much higher. They were the group who identified that this new variant is more likely to affect people who were previously at lower risk. So people like me and many of the other healthcare workers who had been doing very well with all of the PPE. And I have to point out that the Trust, the Royal Devon Exeter Hospital, have done a really good job of stepping up with personal protective equipment when you were hearing about national shortages. I don't know any doctor in Exeter who ever went without the right equipment. With the ventilation and responding very quickly to the changing pandemic. But even despite all of that support, there was still some of us who became exposed and who caught sick in this second wave because of the increased transmissibility of the new variant.
Yeah, it must have been awful. Were you off work for a long time? How did you feel with it?
This is the next element. I spent the usual 2 weeks off work. I then rushed straight back to work and only to be sent home a day or so later, because actually one of the important things about COVID is it does behave differently to many other viruses. Many of us have had flu. I suspect most people here have had some sort of a viral infection. But COVID does seem to knock people a lot harder. And 1 in 10 people who develop COVID will be left with longer term symptoms. And I am one of those 1 in 10. I'm now 4 months later, and I'm still not back to my normal self. I'm still in a position where I get tired relatively easily. I become fatigued after about 3 or 4 hours on my feet with significant leg pain and significant pains anywhere else. And that actually feeds into some of the other research that we've already been doing in Exeter, that we are now turning to this condition of long COVID. So with the advent of long COVID, this was effectively a new disease. And even before the big calls from NIHR, we were already starting to work up proposals of how we can look into it. So if you think about long COVID, it's basically after you've had the virus, you become exhausted, you become very tired very, very quickly. It's like having an old iPhone. And if you've got an old iPhone, you all know that it starts every day fully charged. And after about 20 minutes of use, the battery's almost flat. And having long COVID is just the same as that. Those batteries are wearing out. So we've put together several different projects. And the first, the very simple, we've focused on the strengths of Exeter. And the first study to be up and running is a study looking at the genetics of long COVID. As I said, 1 in 10 people, like myself, end up with these long COVID symptoms. That also means 9 out of 10 people get exactly the same infection and bounce back and do really, really well. So one of the things that we're looking at is what are the genetic predictors of developing long COVID? Because if we can do that, then we can start working on find some sort of risk tools to minimize the risk going forward. And many people have been said COVID is here to stay. It's something that we're going to be living with. So if you could identify who's at the greatest risk of both dying of COVID in the short term and also developing long COVID, it gives us a really good way to say, okay, you've got the highest risk, let's put you into a position where you've got the lowest chance of actually contracting the virus. And then the other thing that we're looking at is what are the underlying mechanisms? What causes it? What basically makes the battery go flat? Now, I said early on that pre-COVID, I was doing lots of work in the microcirculation. They are the smallest blood vessels in the body. They're the ones who actually deliver the oxygen and nutrients to the tissues. I think the best way of describing the microcirculation is like comparing it to a road network. You've got the central hub that's got all the storerooms and everything else. Then you've got the motorways that get the big lorries down to the cities or the towns. Then you've got the A roads that gets from big lorries to smaller trucks that enables you to get into the general areas. And then the microcirculation, they are the cul-de-sacs. They're the little tiny roads, the small avenues, the ones where you actually live. And it doesn't matter how good the motorway system is, how good those A roads are. If the road to your house is blocked, you'll never get a delivery. And the microcirculation is that road to your house. And if the microcirculation gets affected by COVID, and we know that it definitely does in hospital, if it gets affected for those who are not in hospital, who don't get such bad disease in the first instance, like myself, then it doesn't matter how strong the rest of the body is, because the oxygen, the nutrients, and the tissues are never going to be replaced. The byproducts, the waste products, all these things that build up, they're never going to be removed. And as a result, you believe you can do the full day's work because every morning you wake up fully recharged because the drip feed has managed to get things going again. But then very, very quickly, your body starts to suffer from a lack of fresh oxygen, a lack of fresh nutrients. Very quickly, all those toxins in our body that are building up, they cause those muscle aches and pains. So people who are living with long COVID describe it as if they've just run a marathon every day of the week. And we are now looking at this as our next big tool. We're going to take the experiences of those living with long COVID and try and figure out if that is the underlying cause. Because if it is, we then know what we're trying to treat. One of the biggest problems about long COVID for people like me and many others who are experiencing this is that, well, if you don't know what the disease is, it makes it impossible to treat. And long COVID, as we know it today, didn't exist, well, 12 months ago, because COVID didn't exist then. And so we've been drawing on experiences from other treatments, from other disease areas like the chronic fatigue service or myeloencephalomyalgia, a horrible disease in its own right that nobody's really got to grips with. And it turns out that there are huge similarities. So actually, the work that we're now doing in COVID could benefit the thousands of people, if not millions of people worldwide, who are left living with CFS or ME, in the hopes that going forward, we may have treatments not just for that, but also for these other conditions.
Well, let's hope something really good can come out of something really bad.
Silver lining and all that.
Indeed. So yeah, you've talked a lot about Exeter. Do you know much about the more broadly the Southwest contribution, different varying contributions to the COVID response? Or
Yeah, I mean, Exeter has played. The whole of the Southwest has played a really important role, and I think looking at that, we have to start thinking about things like vaccine therapies. You've got to remember, in the Southwest of the UK, we have a demographic that is more mature, shall we say, than the rest of the country. It is a beautiful place to come and retire, and as a result, the population here in the Southwest tends to be of a more mature variety. And it was also very clear that the COVID was affecting the more mature adult far more than the youngsters. And as a result, the COVID vaccination studies, COVID vaccination programs, the Southwest actually contributed tremendously to so many of these. And that's not just Exeter, that's in Plymouth, that's in North Devon, into Cornwall, places around Dorset, Yeovil, all of the places around here, because of the demographics that we've got, that with a higher risk, across the board, we've been contributing more than many other places in the country. And it's actually due to how agreeable, how willing the people of the Southwest have been to come forward for these studies, that we have really good data in the population that are at greatest risk. I mean, in the Southwest, we contributed about a fifth of the patients to the vaccine trials that have been done in the UK. Again, I'm from Exeter, so I know what we've been doing here, but this is across the whole of the Southwest. And as a result, the government have been able to confidently roll out the biggest vaccination program of all time, knowing that it's going to be effective in a population that historically would never have been involved in the trials. I mean, realistically, if you go back 5 years, populations over the 80 were just not recruited to clinical trials. Whereas because of the tremendous effort, and I say this is not just been by the traditional researchers. This has been nurses, GPs, healthcare workers of all ilk have been contributing to this, because this has been such a big, vital program. That's part of the reason that we are now heading out of our lockdown, and hopefully out of the last lockdown that we're going to have. Another thing that we did in the Southwest that was above and beyond, we live on our tourist industry. And actually, the Southwest group put together the standards for trying to get the tourist industry running again. And the nationwide standards for travel, for how you can do things safely, for the ventilation, for the provision of hand washing facilities and the alcohol gel, and the need for these face masks. The Southwest was a big driver on that. The British Medical Association down here, that was led by Lucy Jane Davis, who is a local GP, who's also the chair of the Southwest Regional Council for the British Medical Association. And a group of us put together the what it was going to be a minimum standard in order to have safe reopening of holiday venues. And although, yes, we are coming out of a second lockdown, we have to remember that the Southwest flourished throughout July, August, September, into October, when we could get safe tourism working again. And actually, we did so much better than so many other parts of the country that didn't have these strategies in place. So a lot has to go out to people like Lucy Jane and Richard Rawlings and the team in Public Health England down here that have managed to set standards that the rest of the countries are now picking up, but we led the way.
Sorry, we lost you a little bit at the end there, but yeah, that's fantastic. From your perspective, how is the vaccination program going? Is the path out of lockdown realistic? Are we going to be all right?
Yes, so that's always going to be an interesting question. I mean, what this route map out of lockdown? So the first thing to say, it is great that all of these dates rather, are set as variable standards. They will move if COVID flares up. It's also great that we've seen a move away from we are going to do something in 2 weeks' time, and then we're going to do something in 2 weeks' time, and then something in 2 weeks' time. And the problem with that is, because all of these things have been promised, then there is no way back. And politicians are not very good at standing up and saying that they were wrong. And actually, that's one thing that we do have to almost praise the government for, because they have at last learned that we need a minimum of 3 weeks to figure out what the impact of the last step was. So, you know, the children all went back to school last week. For many parents at home, this has been a godsend, because for all of the benefits of homeschooling, like many others, I was so glad that my children went back to school, because they need that social interaction, and parents also need to be able to focus on something other than trying to figure out how these integers and complex fractions work. I'm sure maths was never like that when I was at school. So the children have all gone back, but we don't know the impact of that. We know that the new variants may be infecting children. We know that children themselves won't get sick, but what we don't know is whether the children can then spread that infection on to us, the parents, and whether we can spread it onto the grandparents. So rather than having a 2-week gap, the government's now moved to a 3-week gap to assess the impact. And the reason for the 3 weeks is we know that it takes between 5 and 7 days for someone to become clinically apparent with the disease. And they're spreading it from about day 3 onwards. So let's say your daughter goes to school today. She picks up COVID or coronavirus for her, because it wouldn't be the disease. She goes to school, she picks up the coronavirus, and it will be about 3 to 5 days before she was at risk of spreading it. Now, chances of her actually getting sick are negligible, so nobody's going to notice that she's sick. She'll bring that home, and about 3 to 5 days later, you, as her parent, may catch coronavirus. And again, younger, fitter, healthier parents are far less likely to end up with significant COVID. It might just be the typical runny nose that we all get when the kids go back to school, so we may not notice it. And it's only then when the next spread of the disease comes, when somebody who is not directly associated with the child, that we start to see a disease appearing. Now, that started from the schools going back, but only became apparent at about 14 to 21 days after the schools went back. And for that reason, you'll notice that instead of a 2-week schedule that we had last time, we've now got a 3-week schedule. We now go in at, was it the 8th of March? The next step is 21 days later, the 29th of March. The next step is 21 days later on the 12th of April. And each of these dates may be pushed back. And that's going to be really difficult. It's going to be really frustrating. We are all looking forward to, I don't know, going to get our haircuts, I guess. Probably not a good example for me, but we're all looking forward to getting into the hairdressers again. We're all looking forward to going to a gym again. And we've got these gates, the days on the horizon, and we are all looking forward to getting into the pub and sitting down and having a chat with our friends and colleagues again.
I just want to see my family.
Sorry?
I just want to see my family.
I know. We had this great ambition that we were going to be in Christmas, and we were going to have Christmas at Easter, because we hoped by then we'd be out of it. My parents haven't seen their granddaughter in 2.5 years. Sorry, 1.5 years almost, it feels like. Actually, no, it feels like forever. But yeah, we just want to do that. We just want to have a proper celebration with our family. But the most important thing now is that we do that in a way that when we come out of lockdown, we stay out of lockdown. And we saw it at Christmas that things were going in the right direction. And then there was this temporary easing of restrictions. And all of a sudden, we've been put back 2 weeks and the peak is higher than it was before. And that was just from a 2 or 3 day leeway. If we come out of lockdown even a week too early, we could be back where we started from. Whereas potentially, maybe just delaying by a week here and there. And we're saying, man, this is all worst case scenario. You never know. We might come out. The vaccine may do everything it's supposed to. And the result would be that we're all out and we're all having street parties on the 21st of June. We're all looking forward to that day, aren't we?
Oh, here's hoping. Indeed. Oh, well, thank you so much, David. That's been really, really enlightening and yeah, made me feel again very proud of the Southwest, because it sounds like we're making some great impact, nationally, but during the COVID response. So yeah, just a massive thank you to anybody who works in the NHS. What an absolute pig of a year you guys have had, and so grateful, because the NHS just does an incredible job, and we are so lucky to have it. So everybody, the researchers and the clinicians and everybody involved in medicine in the UK, I think are just blimmin' amazing. So yeah, thank you, David. Thank you for everything you've done and everything all of the people out there in the NHS have done. And yeah, anything else you want to add about?
I'm sorry, it would be hugely remiss of me if I don't have the opportunity to do a quick name drop of Ray Sheridan, of Tom Whitehead, Steve Patton, of all the nurses on Torridge, Yelm, in the medical emergency department, who have done most of the hard work. And I can't forget the respiratory team. So there's Matt, there's Lee, there's Nick, who've been out there. And I've got to do this because otherwise I'm going to get so much earache tomorrow if I don't. But actually, the medical team, exactly as you say, we have learned about a new disease this year. From medicine, from nursing, from the therapy, the different needs for rehab for these people. This has been a brand new disease. And actually, the NHS has really stepped up. We've seen private contractors come in, Serco, Test and Trace, and you'll all have seen the things a couple of weeks ago saying that that was potentially a big waste of money. However, we've also seen the NHS vaccine program. The NHS has actually done that for the vaccine. It's been entirely NHS hands, and we have a world-leading vaccine program that hopefully is going to get us out of this mess before, well, anyone else in Europe for a start. So yeah, all the credit has to go out to those amazing hard workers on the front line who've been doing everything. And actually, for the people of the Southwest who have listened to the advice, who've stayed at home, who've worn the masks and done the hand gel, because despite how bad it feels here, compared to the rest of the country, we've got off lightly. And that's not because the virus hasn't been here. That's because the people have been listening to the advice, taking it seriously. And as a result, we are doing so much better than big parts of the country.
Yeah. Indeed. Well, thank you so much, David. That's been really, really great. And thank you to all of the speakers that we have had this week. It's for British Science Week. It's been such a fun week, meeting lots of inspiring people, and we hope you've enjoyed it all. Please do go on our website, find out more about what we're doing, fill in our survey so that we can make sure the Science Centre is a place that is useful and enjoyable for you. And yeah, sign up for our newsletters. And I just want to say thank you for Eleanor, who designed our banners for the social media this week. It was a really cool banner, thank you. And just checking if there's anything else I've missed doing. But yeah, thank you for everyone who's tuned in, and yeah, to all the speakers. It's been great. So thank you, David. It was really lovely talking to you, and thank you for all your hard work and the hard work of everyone in the NHS. You're all legends. All right. Thank you very much.
Thank you, Alice.
Thank you, everybody. Bye. Bye.